is very important class clinically. Try to understand the problems and how to solve it. Hemiplegia, you know, is a weakness of the one side of the body. Maybe left side is called left hemiplegia, right side is called right hemiplegia. Now, you know the power of the muscle. They are graded from 0 to 5. Plegia means that complete paralysis. But if the power is less than 5, say 3 or 4, then we call it a hemiparesis. So, it may be right hemiparesis or left hemiparesis or left and right hemiplegia. So, it is a common neurological deficit. Most frequently develops acutely after stroke, which may be ischemic or hemorrhagic. So, hemiplegia, the most common cause of hemiplegia is, there are other causes also, we will come later, but the most common cause is due to stroke, and stroke may be ischemic or hemorrhagic. Site of the lesion is in the contralateral pyramidal tract. You know the pyramidal tract, so it starts from the cortical cells in the brain and also ends in the anterior horn cell of the spinal cord. The whole tract is called corticospinal tract. In the middle it does many functions, we will come later. Therefore, it is always a upper motor neural lesions. You know by definition, upper motor is the starts from the cortical brain cells and up to the anterior horn cell. From the anterior horn cell onwards up to the muscle, they are called lower motor neuron. So, pyramidal tract hemiplegia is always a upper motor neuron lesion. Here you see stroke may be hemorrhagic or ischemic, okay? Hemorrhagic or ischemic. Hemorrhage, so hemorrhage, you know, the hemorrhage is due to the rupture of the blood vessels. Hypertension definitely is the most contributory factor, but ischemic strokes is something different. Ischemic stroke. So, I am just describing how the ischemic stroke occurs. Ischemic. It may be thrombotic, or it may be embolic. What is thrombus and what is the embolus? Thrombus, you know, if this is the artery, suppose this is the artery, suppose this is the middle cranial artery and it is its anterior branch. So, if there is a breach in the endothelium, then there will be propensity to form a clot. If this clot gradually increase and over there is platelets come up and complete blocks the artery in the site where the thrombus is formed, this is called thrombosis. But it may so happen that this thrombus after formation, half formation or not when completed, it get dislodged from here, it get dislodged, uprooted from the here and it obstructs here. Then it is called embolus. So, thrombus is the obstruction where the pathogenesis is where it is formed, complete blockage of the artery at the site where the lesion is. But embolus is not that. Embolus is the distant place. Thrombus is uprooted, dislodged, and then it is obstructing the periphery of the other artery. Same artery in the peripheral part. This is called embolus. So, you know, this thrombus formation is gradual formation. No, there is a gradually there is a cap. The cap is breached. The platelets coming up. Platelets are complete the thrombus and complete block. It takes time. So, here the stroke will take some time to develop. It is a gradually developing. Suppose the patient has a first, there is a paresis of the upper limb, gradually after 2 hours, 3 hours, the lower limb, then it completed after 5-6 hours. So, it is a gradual, it may more comparatively gradual. But embolus, when it dislodge and obstruct it is a sudden. It is a sudden because it is not a gradual formation, it is just obstructing, all on a sudden. So, this is a sudden development, and hemorrhage is also a sudden development. because hemorrhages do not, there is no gradual formation. Hemorrhage is, when the hemorrhage occurs, it occurs suddenly, and whatever lesion is does, it do it immediately. So, this is the basic difference you should keep in mind, the pathogenesis. Now, we are coming to the slide. I am describing this because of this second point, it develops after stroke, which may be ischemic or hemorrhagic. Probably you have now it is clear what is ischemic and what is hemorrhagic. If it is ischemic, it may be thrombotic or may be embolic. Now, the pyramidal tract, you know, it is a corticospinal tract. It is a pyramidal tract. It starts with the corticospinal tract because it starts from the cortex and end in spinal cord, anterior horn cell level. So, it is called corticospinal tract. It originates from three sources, 1/3 from each. Very important. It is a here you cannot see it probably. If you can enlarge this picture, you can see the pictures lower down the right side. That blue area. It is pointer ache na. This blue area is central sulcus. The part in front of it is precentral motor. Here is a precentral gyrus, primary motor cortex. It is a precentral gyrus, the primary motor complex. In front of the motor cortex, the grey area you see, there is a supplementary motor area, and also in front of that, this is a central sulcus, this is a premotor area, and this is a in front of that, this is a supplementary motor area. This is the frontal part of the brain. Now, primary sensory cortex is a postcentral, central sulcus, the parietal, in the parietal part, the postcentral is the parietal lobe. It is called the sensory cortex. Parietal lobe in the postcentral gyrus, area 312. If you can look at this picture, you can understand. This is a central sulcus. Before the central sulcus is premotor area and supplementary motor area, and behind the sulcus is the parietal lobe, is the sensory area. So, it comes from all the three sources. Now, further downwards of the pyramidal tract, you know, if you draw a picture of the pyramidal tract, you know, say, suppose this is a cortex, suppose these are the cortical cells. From the cortical cells, the fiber will come down, this is the cortical cells, fibers are coming down, this is called corona radiata. The fibers are diffuse, not concentrated in one place, but when it comes to the internal capsule, in the genu and also the anterior 2/3 of the posterior limb, it concentrates. Now, all these fibers are concentrating in this internal capsule. This is called internal capsule. It is concentrated in the internal capsule, where there is a genu and the anterior 2/3 of the internal capsule. We will come to the structure of the internal capsule. From internal capsule, it will come down. Internal capsule, you know, this is a structure. There is a compact pyramidal tract structure, and between the thalamus and the caudate nucleus. The picture is there. I will show you. Thalamus and the caudate nucleus and the substantia nigra here. So, then it comes down to the midbrain and also come to the medulla. Then medulla it crosses. And rest of the spinal cord, it comes in the opposite side. After medulla, it crosses and it goes to the opposite side. So, this, if it is the right side of the brain, then it will be represented in the left half of the patient motor system. I think it is clear. Then comes, so it is a corona radiata. The fibers from the corona radiata are what widespread. You can see the fibers are widespread. They are converged together and forms the internal capsule. Internal capsule is a V-shaped structure with the anterior limb, genu and posterior limb. Now, the relations of them, here the internal capsule is prepared. You can say which side the internal capsule it is. If it is in the patient perspective, it is in the left side of the internal capsule. What they are showing, the internal capsule is sequestered into the shaped by the gray matter area of the nuclear deep into the white matter, the caudate nucleus, thalamus and lentiform nucleus. You can see that this is the thalamus, this is the caudate nucleus and this is the lentiform nucleus. So, in between that there is a V-shaped structure. I have already told you that internal capsule has a, this corner area is called genu, and after that is the posterior limb. Anterior 2/3 of the posterior limb is there is a pyramidal tract, but there is rest 1/3 of the posterior limb also. This rest 1/3 carries the sensory fibers from the thalamoparietal radiation. From you know that thalamus is the higher center for sensation. All sensations are converging to the thalamus. Then thalamus, this radiation goes to the parietal lobe. This thalamocortical radiation, it is just behind the internal capsule, just behind the cortical spinal tract in the internal capsule, and also behind that there is a optic radiations, and behind that is also optic and auditory radiations also behind that. So, internal capsule is not complete only by the corticospinal tract. In the same limb, the posterior limb, it also contains the thalamoparietal radiations, the sensory fibers, and also it contains the optic and auditory fibers also. Because clinically we will find that there are lesions where all the three lesions are there. There is a corticomedullary tract, there is a pyramidal tract gone, along with the thalamocortical radiations gone and optic radiations gone. So, there will be three features, no? Along with the motor system, the sensory features will be there, and also the optic those vision disturbance in visions are also there. Those three can occurs together in some cortical lesions. Particularly it is important MCQ, which artery causes these all the three lesions. This is an MCQ, is caused by choroid artery. When there is lesion in the choroid artery, it is a branch of the middle cerebral artery. Choroid artery, where there is lesions, there is all the three fibers can be involved. So, after coming from the internal capsule, you know these pictures, the pyramidal tract courses down through the ventral aspect of the midbrain. The anterior part of the midbrain, pons and medulla, and lower medulla 85% crosses to the opposite side and courses down to the spinal cord. 85% crosses down to the spinal cord, and it relays in the anterior horn cell of the spinal cord directly or mostly via the interneurons. So, you know, if there is any actions, suppose there is a injury in my index finger, the sensation will go to the spinal cord. From there, from the radial nerve, it is supplied by the radial nerve. The radial nerve, it will go to the spinal cord. From the spinal cord, there is a spinal segments, and then it will go to the C5 C6 segments. Then C5 segments will call that they contract your biceps, because there is an injury in the something offensive in your index finger. Then I will contract my biceps. This contraction is done by the C5 C6 anterior horn cells. So, this is this whole reflex is completed in the spinal cord level. Here the upper controls do not come, but there should be upper control. Why? I should not flex it very much, I should not flex it insufficiently. There should be a coordinated and sufficient contraction, so that I can withdraw my hand from the offending agent. This coordination, you know, in previous classes we have already discussed, this coordination is done by the pyramidal and an extramyramidal tract. So, here the corticospinal tract will tell that do not flex it much, and they will inhibit this reflex and call it do not flex it much, it is just flex adequately. So, this way this local spinal reflex is controlled by the corticospinal tract. Previous slide you have already asked, this is a corner, this is a corner radiata, is coming through the mid, this is the internal capsule, is coming midbrain, they have come medulla, it is crossing, 85% of the fiber cross come to the opposite side, 15% parts of the fibers also comes in the same side. They mainly supplies the trunk fibers, central trunk fibers, and the fibers do not cross. They usually supplies the trunk fibers, because trunk fibers are supplied by both the side, not the limb fibers, limbs not. So, commonest cause of hemiplegia, we have already, you know that stroke is the commonest cause, defined as the acute onset of focal neurological deficit lasting for more than 24 hours due to vascular cause. This is a definition of CVA, but cerebrovascular accident was stroke. So, it is a acute onset neurodeficit caused by vascular cause, cerebrovascular cause. Sir, vessel obstruction, you have already discussed the pathogenesis. Ischemic stroke is 85%, ischemic stroke is maybe thrombotic or embolic, and hemorrhagic stroke is 15% cases, they may be intraparenchymal or subarachnoid. Hemorrhage may be intraparenchymal in the substance of the brain, or it may be subarachnoid. You know that subarachnoid space contains the cerebrospinal fluid. If it is in the subarachnoid space, the whole blood will go to the cerebrospinal fluid. It is called subarachnoid hemorrhage. Key findings of the examination of a case of hemiplegia. What you will have to examine in a case of hemiplegia? You will have to weakness of the one half of the body, upper motor neuron. Weakness, you will have to examine the power of the muscle. You know that there are powers 0 to 5 gradation. You will have to grade the power of that muscle you are examining. In acute onset phase of neuronal shock, when the patient is developing this hemorrhagic stroke or embolic stroke, particularly when it is developing very suddenly, there is a brief or maybe a phase of neurological shock. Neurological shock means at that time the whole system is paralyzed. The features of corticospinal, there are the features of upper motor neuron, lower motor neuron, you cannot elicit anything, because the patient is in a features of shock. The whole thing is paralyzed for a brief period of time, that is called the phase of neurological shock, but that will pass off by the due time, and the whole features of upper motor neuron or lower motor neuron lesions will come later. Same things happens when there is a case of paraplegia due to traumatic paraplegia, trauma in the spinal cord. At the brief period of following after trauma, there may be a brief period of spinal shock. In that phase of shock, you may not get the features of upper motor neuron or the lower motor neuron lesion, because the whole system is paralyzed. In case of CVA, it is this type also there may be a brief period of neuronal shock. So, at the phase of shock you cannot get anything. There will be hypotonia, there will be the acute onset of phase neuronal shock, there will be hypotonia, there is hyporeflexia actually, and there will be extensor plantar. Acute neurological, you may not get anything actually. Anyway, but later you should get the features of upper motor neuron lesion. And in case of paraplegia, lower motor neuron lesion at the level of the lesion and upper motor neuron lesion below the lesion. In case of paraplegia, spinal cord lesions. But here there will be spasticity. You know, I have already described in previous class that in the corticospinal tract, the spasticity is also called clasp-knife rigidity. Clasp-knife rigidity, like a knife, in the initial part and the later part you will feel the resistance, and the middle part you may not feel the resistance that much, that is called clasp-knife rigidity. And we also heard about the late pipe rigidity, which is occurs in pyramidal tract lesions. The rigidity occurs throughout the movement of the hand. So, this is a spasticity is called the clasp-knife rigidity, causes clasp-knife rigidity. Then hyperreflexia, the jerks, the part of the hemiplegia, if it is the left side of the half of the body is involved, then all the jerks in the left side will be increased. Hyperreflexia, the knee jerk, your ankle jerk, your biceps jerk, all jerks will be increased. There is a extensor plantar response. Plantar on that side, the plantar response will be extensor. And hemiplegic conduction gait. There are different types of gait. Now, hemiplegia gait is, patient walks he half circle the paralyzed limb and try to come it to the midline. This is a circumduction gait. This is called circumduction gait or hemiplegic gait. Similarly, paraplegia patients, when both the limbs are paralyzed, lower limb paraplegia, both the lower limbs are paralyzed, the gait is called scissor gait. because patient scissor this way, this way, this way, this way. This is called scissor gait. Paraplegia patients. There are different sub gait you have heard. There is cerebellar lesions, there is waddling gait. Waddling gait, the patient walks in a broad based foot, broad based walk. That is called waddling gait. So, there are different types of gait. In sensory lesions, sensory fibers when they are gone, the nerve or the sensory tract when gone, it is called high stepping gait. So, there are the different types of gait I have already described to you. Hemiplegic gait, circumduction gait, scissor gait, what is a scissor gait, paraplegic gait, cerebellar gait, the neuropathy gait is a high stepping gait. These are the types of gait. Now, specific localization feature. After hemiplegia, you have got a case of hemiplegia, you will have to localize where the lesion is, in which part of the pyramidal tract. I described the pyramidal tract starts from the cortical cells and ends in the spinal cord level before the anterior horn cells. Where the lesion is, which is the level of the lesion, you will have to determine. So, if the lesion is in the cortex, we call it a non-dense hemiplegia. Why it is non-dense? Because you have already can go through the picture. Then if the lesion is in the cortex or in the corona radiata, then very few fibers will be involved. Very few fibers could involve if there is a lesions in the cortex or the corona radiata, because the fibers are diffuse. That's why they are called non-dense hemiplegia. It may be associated with cortical aphasia. You know that Broca's area in that previous picture is the Broca's area. If they are in the non-dominant hemisphere, in the your dominant hand is the left side, then it is a non-dominant hemisphere. There will be if the lesions is there, if the Broca's area is involved, there may be aphasia. So, this is the Broca's area involved and aphasia is a cortical sign. It indicates the lesion is in the cortex. But one thing has to be clear, that the speech defect we see in hemiplegia patients not always cortical, because a cortical lesion causes complete aphasia. Patient cannot utter any word, that is motor aphasia. But if the lesion is due to muscle, suppose the facial muscles are involved, patient cannot talk. But that is not the lesions due to motority or aphasia. That difficulty in talking also called dysarthria. That is called dysarthria. So, there is a difference between aphasia and dysarthria. If the patient can phonate words, trying to say the words, but he cannot articulate it properly because of the muscle paralysis of the facial muscles. That has nothing to do with the cortex. With the cortical lesions, there is a complete aphasia. Patient cannot utter any words, but if the patient are trying to utter any words, whether there is a speech is little slurred due to muscle paralysis, that is not the cortical lesion, that is called dysarthria. So, dysarthria is not a cortical sign, it is a sign of the peripheral muscles are involved, but aphasia is a cortical sign. Anyway, another cortical sign is also that it causes seizure or it causes convulsion. If the lesion is the corona radiata, there is non-dense hemiplegia. Suppose the patient will come with a monoplegia only, only my hand is not moving. Complete hemiparesis is not possible in lesions in the corona radiata. Then internal capsule, we know that the fibers are very dense. Here only possible there is a complete hemiplegia when the lesion is in the internal capsule. There may be hemianesthesia. I have told you that thalamocortical fibers are there, and hemianopia. I have told you that there are optical radiation fibers are there. So, when these three occurs at a time, hemiplegia, hemianesthesia, hemianopia, this is a triad. This triad I have already told you, this is already involved in the choroid artery. It can involve all the three. If it is in the mid, now it is coming down. If it is in the midbrain, then there is a contralateral. In the midbrain, you know that the fibers has not crossed. It is not yet crossed. It will cross at the level of the medulla. So, in the midbrain lesions, the hemiplegia before that midbrain, all lesions right side of parietal, right side of brain lesion will be reflected on the opposite side, the left side. So, this is a midbrain lesions hemiplegia in the contralateral. CLV is contralateral hemiplegia with third nerve, Weber or sixth nerve lesions. Pons. The midbrain, you know, after it has left the internal capsule, it will come to the midbrain, and midbrain also contains nerves, cranial nerves, cranial nerves, midbrain and pons, they also contain cranial nerves. So, if there is involvement of the midbrain or the pons, there may be there should be involvement of the cranial nerves also. So, when you find a case of hemiplegia with involvement of the cranial nerve, the lesion, the area of lesion, the site of lesion may be in the midbrain or in the pons. In the pons, you know that there are 6th and 7th nerve lesions are there in the pons. So, it will called Millard-Gubler syndrome. When the 6th nerve is not 7th nerve palsy. When the 6th nerve palsy is developed with hemiplegia, it is called Millard-Gubler. When 3rd nerve with opposite hemiplegia, it is called Weber syndrome. So, these are the syndromes that is described because it involves the cranial nerve at the midbrain or at the pons. If it is the medulla, it will involve the hemiplegia with the 12th nerve. Note the medulla contains last 4 cranial nerves, 9, 10, 11, 12 are in the medulla. So, there may be 12th nerve palsy or hypoglossal. 12th nerve is the hypoglossal nerve palsy. It is the midbrain, it is in the medulla involved, we got hemorrhagic. You know, it is also called lateral medullary syndrome. It is involved by important artery. If we get time, we will discuss the arteries. But there is a posterior inferior cerebellar, it is a pica, posterior inferior cerebellar artery is the important artery of the vertebral system. When it is involved by stroke, it causes a lateral medullary syndrome. That lateral medullary syndrome, there will be hemiplegia on the opposite side and also 12th nerve palsy on the same side. Because when it is supplying the 12th nerve, it is not crossed yet. After that, it will cross. So, 12th nerve palsy. So, by examining the patient at the different cranial nerves, you can guess which part of the brain the stroke is involved. It is in the pons or in the midbrain or in the medulla. You can only localize it by examining the cranial nerves. That is very important. Cranial nerves are important, very important to examine. Now, disease affecting the pyramidal tract leads to contralateral hemiplegia, that you know. Stroke causes I have told you the most of the cases there is stroke, ischemic or hemorrhagic, that is called stroke, but other causes by definition are not called strokes. Like hemiplegia may be occur due to demyelination or multiple sclerosis. You know, there is a nerves are myelinated, these fibers are myelinated fibers. If there is a demyelination, there is a disease, multiple sclerosis is a disease where there is demyelination that causes impaired functions of the nerve. That demyelination is also called multiple sclerosis. It is called multiple sclerosis that may cause hemiplegia, but definitely that hemiplegia will be developed very gradually and not complete. It will be partial hemiplegia and develops very gradually. But demyelination is a process, very gradual process, also recurrent process also. Sometimes it improves and after that 1-2 years patient does not feel anything, then again comes up. So, it is a recurrent, very slow process, demyelination. The myelination sheath is lost due to autoimmune destruction of the myelin. This is demyelination. Anyway, in head trauma, you know that head trauma, there is a trauma in the head, there may be hemorrhage inside, there may be hemiplegia. But by definition it is not stroke. Why? Because in the stroke definition I have told you their lesion should be vascular. Head trauma, mathaয় বাড়ি লেগেছে, it is not a vascular lesion. সেই জন্য vascular, definitionটা very carefully read the definition. It should be a vascular cause. That we call a stroke. Anyway, brain tumor, definitely glioma. If there is a brain tumor, glioma, very slow growing brain tumor that will develop gradually, that is hemiplegia. These are the patients develop hemiplegia over months, over years they develop. Infections, encephalitis, brain abscess, tuberculoma and toxoplasma, these are the lesions in the brain that can involve the parenchyma, then also compress the corticospinal tract and cause hemiplegia. Complicated migraine, there is a type of migraine where there is hemiplegia, migraine class we have described. Post-seizure paralysis, also called Todd's paralysis, that we also have described, that is post-ictal paralysis. After a period of convulsion, there may be a brief period of paralysis of the limb. At that time, if the patient comes to you just after convulsion, you may find there is a hemiparesis, but that hemiparesis is not persistent, that is post-ictal or post-convulsive, that will pass off within hours, but may persist for a few hours also. Risk factors of the ischemic. So, now you have understood the strokes, how it is developing and how it occurs. Now, risk factors. For the risk factors for stroke, there is non non-modifiable the risk factors are always divided into non-modifiable and modifiable. What is non-modifiable? Non-modifiable is out of our hand, we cannot control it, patient also cannot control it. This is non-modifiable. This is advanced age, this is out of a patient's hand, patient cannot control his age. Male sex, there is a risk factor for stroke, but patient cannot control his sex. Family history of the stroke. If there is a father is suffering from suffered from stroke, early stroke, or his mother suffered from early strokes, or his grandfather suffers from early stroke, that factors is not controlled by the patient. That is why they are called modified. These non-modifiable risk factors, but that also potentiate the risk of the patient to develop stroke in his future life. So, modifiable. Now, in the below there is modifiable risk factors. What the patient can modify, patient can control. There is systemic hypertension. Yes, if you treat properly, patient if takes proper drugs, antihypertensive drugs properly, then he can control his hypertension. Diabetes mellitus, same. If the patient can control, take drugs regularly and control his diabetes, that risk factor will be minimized. Dyslipidemia, that also can be controlled by medications, but these all are the risk factors of stroke. They develop this, if these are present patient, the patient, if they are present in the patients, they will develop stroke in the early life. And smoking, definitely smoking is a modifiable risk factor, patient can quit smoking, no harm. And vasculitis or SLE, these are the diseases. SLE, you know, there is a systemic lupus erythematosus. There are other rheumatological diseases also, ANCA positive vascular, ANCA ANCA, antinuclear cytoplasmic antibody. So, they are ANCA positive vasculitis, these are called vasculitis. This also can cause stroke, but these autoimmune diseases can cause stroke, that is that patient, that can be also controlled by medicines. The common risk factor for cardioembolic stroke. Now, here is a cardioembolic stroke. This is a different causes of developing stroke. I have told you that, now come to this embolus has come from here, it has dislodged and come to this place. But suppose patient is having you can see this picture. Okay. So, here is the heart, suppose it is a left atrium, it is a left atrium. Can you see this picture? Yes, it is the left, suppose it is the left atrium. So, you know, the left atrium is vulnerable because it is draining blood into the left ventricle and there is a mitral valve. If the mitral valve is stenosed, then left atrium is enlarged. After enlargement, there is a stress in the left atrial wall, and the stress causes to develop a focus in the left atrial wall, that causes atrial fibrillation. That causes atrial fibrillation. So, this is the important cause of atrial fibrillation, mitral stenosis. Mitral incompetence is also same thing. Blood again enter into the left atrium. Again left atrium is in stress. Again left atrium dilates. In mitral incompetence also. Again there is a stress in the wall, and the wall there is a development of a extra focus that causes atrial fibrillations. Other than heart causes, there are other important causes of atrial fibrillation also, but remember at least one, thyrotoxicosis. Very often we see in our practice, the thyrotoxicosis causes atrial fibrillation. So, any cause, maybe cardiac causes, maybe heart cause, that can cause left atrial enlargement and atrial fibrillation. Atrial fibrillation, you know, the atrium is not contracting, it is just vibrating, no effective contraction of the left atrium, it is just vibrating like this at a very high speed, more than 250, it is vibrating left atrium. When it is vibrating, not contracting, there will be definitely stasis of blood. Blood will accumulate there, stasis. There is no movement. If their blood has not in movement, that blood will develop clots. So, what will develop? It will develop clot. What the clot is in the left atrium? Clot. Now, left atrium clot will come to the left ventricle, and from left ventricle you know that aorta. It will go to the aorta. From the aorta it will go to the middle cerebral artery. It will go to the middle cerebral artery. Carotid artery. The carotid artery is directly, there is a direct continuation is the middle cerebral artery. So, middle cerebral artery, again that embolus can dislodge here. So, not only the dislodgement of the thrombus from the area where it is from, it can come from the heart also. It can come from the cardiac also. This is called cardioembolic stroke. The cardioembolic stroke can be caused by atrial fibrillation. Infective endocarditis, you know, again there is an infection in the endocardium. That infection is cause thrombus. That thrombus will be septic thrombus, because it is a contained organism. It can septic thrombus. That is it. If that dislodge and goes into the stroke, causes stroke, that area may develop abscess also, because this if it is developed due to endocarditis, it is a septic thrombus. Anyway, other causes are myocardial infarctions. Again, if there is a myocardial infarction, there is a left ventricular infarction. Left ventricle cannot contact properly. There will be formation of clots, and again it will go to the same way. It will go to the carotid artery, middle cerebral artery, and go to the brain and can cause stroke. Prosthetic heart valve means there is a heart valve. You know, there is a mitral valve replacement or aortic valve replacement. Suppose the patient had valvular lesion and the cardiac surgeon has replaced the valve. Then particularly if it is a metallic valve, there are two types of valve used. There is a metallic valve and prosthetic valve. Metallic valves are steel, formed by steel valve. Particularly this metallic valve, they are very prone to develop thrombus, because the artificial agents you are introducing in the heart, that will cause thrombus formation as a dislodge. And left atrial myxoma, there is another disease, as a tumor develops in the left atrium, that also causes obstruction of the mitral area, then also is an important cause of mitral stenosis also, the left atrial myxoma. So, these are the cardioembolic stroke. So, other than this thrombus and hemorrhage, stroke can occur, you have learned that stroke can occur from cardiac source also. Common risk factor for hemorrhagic stroke. Now, we have discussed about thrombotic and hemorrhagic embolic stroke. There are risk factors for hemorrhagic stroke also. Systemic hypertension is important. Hypertension is an important risk factor for hemorrhagic stroke. Old age, there is a amyloid angiopathy, vascular is a permeability is more. There is maybe, if there is a bleeding disorder or the patient is taking some anticoagulants, then there is a risk factor for developing hemorrhagic stroke. And alcoholism is a independent risk factor for developing hemorrhagic strokes. Aneurysm formations, the berry-aneurysm and subaortic, I have told you that there is an aneurysm formation in the artery, that aneurysm causes rupture. That rupture will cause hemorrhagic stroke. And there is arteriovenous malformation. There is a communication between the artery and vein, that arteriovenous communications are very prone to develop. They are usually congenitally there, but later develops this aneurysm and rupture. So, these are the causes of hemorrhagic strokes. This slide and following slides, these two slides are very important slides. You should memorize it. You should memorize it before going to exam. So, how to differentiate ischemic from hemorrhagic stroke? I have already told you these things. These are just represented in a table form. So, ischemic stroke, epidemiology, most common 85%, I have already told you, and hemorrhagic stroke is 15%. Early impairment of consciousness, ischemic stroke, I have told you less likely, because it is developing gradually, particularly if it is thrombotic. But hemorrhagic stroke, there is a more sudden onset, early impairment of consciousness. Then headache and vomiting, less common. Hemorrhagic stroke is most common, because the events are stormy events, like a storm that has come as a hemorrhagic stroke. Papilledema less common and more common, because there is a hemorrhage, there is a chance of raised intracranial tension. Is the blood volume, if the blood is added to the brain volume, then it will raise intracranial tension that can cause papilledema. Then mortality. The hemorrhagic stroke, definitely mortality is very high compared to ischemic stroke. CT image, we get a ischemic stroke is a hypotense area. Hypotense area is a black, it is look like a black area. It is called hypotense area, and hypertense area is a white area. So, hemorrhage causes hypertense area, because blood contains calcium, and that calcium will cause gives a picture of a white pictures. not black. But if there is only ischemia, only brain parenchyma is gone, infarct picture is always a black area. I will show you the pictures. Then treatment, you know this, the treatment in the thrombolytic drugs and anti-epileptic drugs. If there is convulsion, we can use anti-epileptics and also thrombolytic drugs. Here, if there is a embolus or a thrombus, you will be benefited by giving a thrombolysis. By doing thrombolysis, there are medications which can dissolve this clot by thrombolytic drugs. You know that if there is a slide will come later. So, thrombolytic drugs will benefit it, but hemorrhage never thrombolytic drugs, because there is a hemorrhage, thrombolytic drugs will give you, there will be more hemorrhage, never given. So, this is contraindicated, thrombolytic drugs are contraindicated in hemorrhage. They are managed with anti-edema measures and surgery. Anti-edema measures, there is cerebral edema, intracranial tensions, we can follow the treatment of raised intracranial tensions, and in rare cases we can try also the extraction of the blood from the brain. There is the extraction of the blood from the where it is there is hemorrhage, there is surgery can also help you. Now, how to differentiate thrombotic from embolic stroke? Previous slide was thrombotic from hemorrhagic. Now, again you have know that thrombotic or embolic stroke. So, thrombotic stroke, I have already told you the mechanism is in situ thrombus formations in a cerebral blood vessels often occur in a pre-existing atheromatous plaque. I have already described with this pathogenesis. Embolus is there is dislodged a migrated thrombus form a potential large blood vessels or heart. I have told you about cardiac source of how the heart can be the source of a stroke. I have described. Now, stroke systemic onset often in sleep occurs during night iocanic period. Embolus usually occurs in a patient when the patient is up and about moving, and there is a more chance of dislodgement of this thrombus. The dislodgement chance is less when the patient is in sleep. So, if the stroke occurs in sleep, there is a more chance anything can occur at any time, no problem, no issue, but there is more chance of developing thrombus when it is developed in sleep. But the stroke symptoms progressions, I have told you that thrombus that is gradually progressing, because the thrombus is forming, is in a formation and it is taking some time to form. So, it is a gradual, and this embolic strokes usually deficit occurs at the maximum deficit, maximum neurodeficit at the onset, because embolus that struck it suddenly. So, patient whatever the neurodeficit hemiplegia or develops very suddenly and almost complete at the onset. Now, seizure less common, it is more common in embolic stroke because it is sudden. Hemorrhagic transformation less common, it is more common. Hemorrhagic transformation means embolus causes the ischemic area and there is a hemorrhage inside the ischemic area. That is called hemorrhagic transformation. It is a large infarct may develops the hemorrhage inside the infarct area. Anyway, so but risk factors I have already told you, there is hypertension, diabetes, risk factors are there, but embolic stroke risk factor is atrial fibrillation, prosthetic valve, myocardial infarctions that I have already described. The cardioembolic stroke, rapid recovery less common, likely if small emboli. If it is a very small emboli, suppose is a small artery develops, involve the internal capsule of small area, then these are called lenticulostriate arteries. Lenticulostriate arteries. These are the most common arteries developed in stroke. They are the direct branch of the middle cranial artery, lenticulostriate artery. This thrombus usually I have told you, if there is a thrombus in the middle cranial artery, there is a chance of developing it goes to the direct branch is lenticulostriate. Several lenticulostriate arteries are there that supplying the internal capsule, and that one lenticulostriate artery is involved, they get the embolus, and one very small portion of the internal capsule is involved. That is the most common causes of this pathogenesis of this stroke. Now, what is TIA? Transient ischemic attack. TIA, what is transient ischemic attack? It is the focal neurodeficit develops and complete recovery is within 1 hour. This is called transient ischemic attack. The best imaging modality of this to know if there is any evidence of permanent neurological deficit after an MRI. So, if you do it the CT scan or MRI afterwards, there will be no picture, nothing lesions in the TIA, but patient develops this all these types of hemiplegia or neurodeficit and graduate and almost in 1 hour or so it has there is complete recovery without any neurodeficit. So, TIA is a medical emergency, you know that just because the patient has no neurological deficit and the time of presentation, the doctor could not consider as TIA as a benign fitting issue. But at the presentation you do not know the patient has developed TIA or the patient will develop a full-fledged stroke. At the time of risk factors for the ischemic stroke need to be identified and appropriate optional medications should be given. This TIA is also a stroke, but it has developed, it has passed off, but all risk factors should be taken care of because the patients will develop very chance of developing strokes in near future. Antiplatelets medications and the aspirin clopidogrel need to be started. These are the antiplatelets, you know, these agents are used to prevent this cardioembolic stroke and also this thrombotic stroke and embolic stroke. Now, this is the picture infarct versus hemorrhage. You know that this is this is see there is a hyperdense area. This is a hypodense area, black area, hypodense area. This is ischemic stroke. This is a hyperdense area. This is hemorrhagic stroke. So, before giving thrombolytic drugs, you should exclude hemorrhage at least. You should, before giving thrombolytic drugs, you should do a CT scan at least, and CT scan you should do a just exclude hemorrhage because this hypodense area infarct image may take some time to come up, but hemorrhage usually comes instantly. So, you should exclude hemorrhage before embarking on giving thrombolytic drugs. This is a subarachnoid hemorrhage. In this place on the right side, this is subarachnoid hemorrhage. This I have introduced subarachnoid space. Usually there is an anterior communicating artery, you know, the two anterior spinal arteries, two anterior cranial arteries. They are communicated by an anterior communicating artery to complete the circle of Willis. This anterior communicating artery is mostly involved in subarachnoid hemorrhage that communicates between the two anterior cranial arteries. Anyway, that causes hemorrhage. This hemorrhage is in the subarachnoid space. There is subarachnoid hemorrhage. Here there is a big hemorrhage, you know, big hemorrhage. That hemorrhage has entered into the ventricle also. This black area is ventricle. That hemorrhage has entered in the ventricular hemorrhage. So, this is the subarachnoid interventricular hemorrhage. Initially, it was a parenchymal hemorrhage, but that has the hemorrhage was very big and it involved the ventricle and it has come to the goes to the ventricle also. So, it is a interventricular extension of the hemorrhage. Now, investigation in stroke. What investigation will be stroke? Routine blood cultures, you know that all this lipid profile etc. There is risk factors, but their ECG will tell you whether there is any atrial fibrillation or not. CT scan of the brain, non-contrast we will do to exclude hemorrhage because we are planning to give thrombolytic drugs if the patient comes within 4.5 hours of the stroke. If the patient comes within 4.5 hours of the stroke, we should try a thrombolytic drugs. So, but you should exclude hemorrhage at least before giving thrombolytic. So, you should do a CT scan before in the MRI brain diffuse weighted images have to know whether the lesion is acute or chronic. So, immediately you do not need MRI. For that immediate treatment you need a CT scan is non-contrast CT scan is sufficient for exclude hemorrhage. But mind it, in children below 12 years of age, CT scan is not a good guide. Here always you will have to do MRI directly in children below 12 years because their CT scan is not a good guide, it has been seen. That so they should always go for MRI directly before doing CT scan. Anyway, so carotid artery Doppler Carotid Doppler, you know, the ultrasound Doppler of the carotid arteries will tell you whether there is any thrombus in the carotid artery or not. That is the investigation part of it. And echocardiography, you know that echocardiography is a investigation of the heart that will tell you whether there is a valvular heart disease, they are not, whether there is a clot in the left atrium or not, etc. They will either get many informations after doing a echocardiography. Now, treatment of choice in ischemic stroke, recanalization produces thrombolysis. Window period is 4.5 hours from time to the onset of stroke consumption. When a patient starts developing symptoms, up to that, if the patient reaches in the emergency room, and if you are in the duty in the emergency room, if the patient comes within 4.5 hours and the patient is conscious, not unconscious, we never do a thrombolysis in an unconscious patient. The patient should be conscious, and you have done immediately you have done a CT scan, you have exclude hemorrhage, then immediately you should do a thrombolysis of the patient. This is your moral duty in emergency room to do a thrombolysis. If it comes within what drugs we used? We use RTPA, combinant drug, tissue plasminogen activators. 0.9 milligram per kg over 1 hour IV infusion. This is a 0.9 milligram per kg over for IV infusion for 100. This is done for Altiplase. There are two types of drugs are in use in TPA. There are several others, but two types of drugs are available in the market. One is Altiplase, one is Tenecteplase. This is the dose given for Altiplase. But nowadays most of the centers they are using Tenecteplase. Why? Because Tenecteplase has got some advantage. Like you are giving it in infusion, but Tenecteplase you can give it in a shot. You do not have to wait for 100 ml for 2 hours. You don't wait. You need not to wait. You got to give it in a shot over 2 minutes, 5 minutes. Over 5 minutes you give the shot. You have to wait for 5 minutes. Here you have to wait for 2 hours. For 100 ml go slowly. So Tenecteplase is more convenient and is more available nowadays. And the dose is also very convenient, because in case of ischemic stroke it is 0.25 milligram per kg of body weight, Tenecteplase. So whatever the patient's weight is, you just divide it by 4. If the patient is 60 kg, you give him 15 milligram Tenecteplase, and it is given in IV shot. So all are very convenient. So that's why Tenecteplase are more used in nowadays in cerebral stroke. But these are the dose given for Altiplase. Supportive care, definitely after this you have done thrombolysis or you have given all this treatment. After that the patient during discharge, you have to after that everything, you have to take care of the other symptoms of the patients, like patient is vomiting or patient cannot take food, you have to put a Ryle's tube. That Ryle's tube also prevent from aspiration also, because many of the patients of cerebrovascular accident patient dies of hemorrhage, dies of aspiration. So this Ryle's tube, you should put a Ryle's tube to prevent this aspiration. Now there is a Foley's catheter you should put, because the patient is unconscious in a shock stage, patient will develop retention. And bed sore prevention by keeping the back dry, passive change of the movement of the joints, DVT prophylaxis. You know, any limb lying for a long time without moving, that is a risk factor for developing deep vein thrombosis. The vein will get thrombosed, and that thrombus may dislodge from there. Where they will go? If suppose a thrombus from the femoral vein dislodge, where it will go? It will go into the pulmonary bed. Now veins will drain. The veins will drain into the where? Right atrium. From right atrium it will go to the right ventricle. From right ventricle it will go to the pulmonary bed. There is a deep vein thrombosis. The thrombus will go and go to do the pulmonary infarction, pulmonary embolism, but it cannot do systemic stroke, because there is no chance to go to the left side. From the pulmonary bed, how it will cross? So it will stuck into the pulmonary bed, that will cause deep vein thrombosis, will cause pulmonary embolism. Unless there is a ESD or VSD, if you get an aperture in the heart, after getting into the right atrium, it gets the aperture in the ASD and goes to the left atrium, then there is a chance of stroke, goes to the brain. But see, if there is no communication between the two atrium or the two ventricle, there is no chance for the clot from the deep vein thrombosis will go to the left side. It is all things will be right in the right side. Anyway, the physiotherapy and antispasticity measurement like baclofen and tizanidine, these are the two drugs which just this causes this and some relief in spasticity this can cause. They are mostly injected there. Treatment of risk factors and comorbidities, I have told you hypertension you should treat, and another this is a important contraindication for giving. I have told you, the patient has come after 4.5 hours, but you have find that the 4.5 hours and there is no hemorrhage, but patient should have a blood pressure less than 220 by 110, or you cannot use thrombolytic drugs. You should reduce the in that case what you will do, you will reduce the blood pressure by giving labetalol, and after that if the 4.5 hours window is there, after reducing the blood pressure, if you get chance you can try for thrombolysis in that patients also, after reducing the blood pressure by giving IV labetalol. So, hypertension is a contraindication. This type of hypertension is a contraindication for giving thrombolytic drugs. So, the acute phase of stroke provides transient reactive hypertensions, euglycemia is quite common in stroke. Transient after that, even that after the embolic stroke and thrombotic stroke, patient develops hypertension transiently. But that hypertension should not be reduced, because this hypertension is protective to the patient, because this is a reactive hypertension. Patient that the patient is trying to, the system of the body is trying to give more blood pressures to reach the blood to the ischemic area. So, it is a protective, that hypertension you should not treat in case of ischemic and embolic stroke. Euglycemia to be maintained, yes, diabetes, the blood sugar level is always deteriorates the your outcome. So, blood sugar should be maintained and antiplatelets and statins should be given. Late complications after hemiplegia, just going through rapidly, seizure, persisting focal neurological deficit, spasticity, these are developed after late complications, contracture, pain and stiffness in the joints, frozen shoulder and subluxation of the shoulder and falls. Hemiplegia patient can fall. So, these are the late complications of a hemiplegic strokes. The next day we will describe this